lecture here. I will start with a case of mine, 48 years, young male who has a poor diabetic control, had both eye fully mature cataract, had PDR with a laser PRP was done and the intravitreal injection was also given. He underwent an uneventful phaco with IOL using Helon and between the 3 days interval, and post-operative day 1 in both eyes was within normal limit. After 3 days of the second eye surgery, left eye surgery, he came suddenly with the sudden onset of severe eye ache, headache, and severe diminution of vision. The vision reduced to counting figure 2 feet, and he has a very, very shallow anterior chamber, no cells, no flare. Convection color was also not seen. The injection mannitol was given as the pressure was 54 millimeter of mercury after consulting his physician. And daily it was given for 3 days, but the IOP never came down. All the suggested treatment was given. And this is the intersegment OCT picture as well as slit lamp examination showing you an inflammatory membrane, giving the pupillary block mechanism and a very, very shallow chamber. But IOL you can see was way behind. So it was a typical pupillary block syndrome. So what to do here? So I am going to talk on the elevated intraocular pressure making your patient unhappy after the surgery. Post-operative raised IOP is common, but majority of the cases are asymptomatic and it is transient. The peak IOP between 30 minutes to 4 hours after surgery is a common thing. IOP more than 28 millimeter of mercury was seen in 18 to 45% of the cases. The glaucoma could be primary pre-existing glaucoma or it could be secondary, and primary glaucoma may be newly diagnosed or missed before you do the cataract surgery, and secondary is usually related to the cataract surgery, early onset or it could be late onset. Why there is an unhappy patient? Because there is a mismatch between the expectation and the outcome. You are doing a premium IOL, patient is expecting a miracle, asymptomatic post-op, early rehabilitation, and decrease in the number of medication if he is a known case of glaucoma. But outcome is different. Patient is now symptomatic. It could be in form of pain, watering, redness, narrowing of the palpebral fissure, and suboptimal vision. As I said, the early onset IOP rise is usually secondary in nature. The etiology can have a various mechanisms like retained OVD, inflammation, lens debris, or pre-existing glaucoma. And mostly it is the aqueous humor flow drainage obstruction, and diagnosis mainly is clinical. The treatment should be individualized according to the etiology and try to avoid the PGs and pilocarpine in this case. Big no to them. Initial therapy is to control the IOP medically. One can use topical and systemic aqueous suppressants. Timolol, brimonidine, and are preferred over the carbonic anhydrase inhibitor. And cycloplegia, use if you have a dilemma in the diagnosis. Subsequent management can be in the form of laser if it is a pupillary block, SLT for open angle glaucoma, and surgery is the rarity which is required in these cases. So coming back to the patient I started, so we lyse the membrane with the YAG laser, and you can see that immediately after the laser there is a deepening of the chamber, and at the end of 1 month everything was and patient was happy, we were also happy. Vision 624 was because of the bad macula due to diabetic retinopathy, but the IOP was normal, patient was off the treatment. Another cause could be the hyphema. Here also it usually self-limiting and resolves without any complication. Paracentesis is rarely required, and start using the aqueous suppressant with the corticosteroid. This is very commonly seen these days as we all glaucoma specialists are doing GAT surgery when we do the cataract surgery. And GAT has one of the main complications is the hyphema. May not be on table but can happen after 2 or 3 days. Uveitic glaucoma is more common with the pre-existing uveitic or complicated cataracts. Then here also the corticosteroid plays a main role. Control it by using the oral systemic or the topical corticosteroids in a more doses. Cycloplegia is must, and iridectomy sometimes is required if there is a pupillary block mechanism. The pupillary block can be there in the early phase, but I have seen many patients coming after months of cataract surgery with the pupillary block mechanism. Most common cause usually is with the angle closure glaucoma following cataract surgery and can occur in the presence of even peripheral iridectomy. So may present days or weeks following the surgery. Iris bombae is a typical sign with the elevated intraocular pressure and occlusio pupillae. So the management is in try to dilate the pupil first, and then if it is not happening, you have to do laser iridectomy, and then IOP reduction medication should be started. Another case I would like to mention, uneventful surgery. On 4th day, patient came with acute headache and blurring of vision, and all the treatments were given by the treating doctor. He was referred to us for the second opinion. Iris surface, if you see carefully, the black pigments all over were seen, and gonioscopically, the TM was showing jet black pigmentation in 360 degree that was giving the obstruction to the outflow facility. So diagnosis was severe inflammatory response, and pigments black, we suspected ciliary body was affected. Now pre-existing glaucoma patients where the cataract surgery were done, there is always a risk of bleb failure, and the management is again a medical therapy. But the counseling should be done in these patients that they might observe the rise in intraocular pressure following the cataract surgery. The malignant glaucoma can occur if patient has angle closure glaucoma, which is a high risk here, and degree of the angle closure, how much was there at the time of surgery, will also give you some clue how much is the risk. And it should be differentiated from the choroidal detachment or pupillary block or suprachoroidal hemorrhage. The management for me, if it is early case, atropinization is must. Patient may have to use this for a long period or sometimes even lifetime. And YAG laser can be used to disrupt the anterior hyaloid phase. You may not do it in the center, can be done in the periphery if there is a PI pattern. Through that you can do the hyaloidosis. UGS syndrome is not seen these days a lot. It was because of the imperfect selection of the IOL design or improper placing of the IOL. Here it is shown that one haptic is in the sulcus and other in the back, and this was giving him a high pressure. So repositioning or removing of the implant and doing again can be of help in this case. One should not forget about the PACs. Though patient may not have a rise in intraocular pressure, but in their lifetime it can happen. So counsel the patient regarding the lifetime follow-up. And gonioscopy is must when you do the traumatic cataract. Look for the angle recession or the synechia. Again, they are advised for the lifetime risk of developing glaucoma. In pediatric age group, incidence of glaucoma following congenital cataract surgery ranges from 1 to 32, but remember, the risk of developing glaucoma after pediatric cataract surgery continues throughout the life. And these are the factors which can give the high risk factor. So in end, what patient doesn't know, surgery is routine for us, but it is once in a lifetime experience for patient. So even a small pain or foreign body sensation should be addressed immediately. Patient will interpret as a complication. He is not expected to know something as benign as a foreign body sensation or not aware that blurry vision may occur after surgery. So reassurance goes a long way. There is always a fear of vision loss when they know about high intraocular pressure. So clear communication, counseling will always save our life. Patient education should be done before the cataract surgery, and prompt intervention should be done. One should be patient to listen to them and always have a positive office vibes, because as soon as patient enters your office, he will start evaluating everyone. So thank you very much.
Thank you, Dr. Mayuri KHAMAR, for your excellent presentation.